Hello, I'm Dr. Israel Barken, the Medical Director of the Prostate Cancer Research and Education Foundation, and we are going to talk this time about focal treatment, but this time we are going to talk about the good old-fashioned radiation. Usually radiation was given over the whole gland, and it was never attempted to give it in a focal manner. It's interesting because the focal therapy came to existence because of fear of adopting the active surveillance by itself, because of patient anxiety, and patients' fear of getting side effects from treatment. So it's kind of middle of the way, middle of the road here to choose focal therapy. The other factor that brings focal therapy up front is the fact that now we have imaging test that enables us to have one, better localization of the tumor, two, guide the treatment in a better way, monitor the treatment real time by using imaging, and three, having those same imaging tools to be able to follow up and judge the success or failure of the focal approach. What helped a lot is the fact that technology advanced by itself, the technology of applying the energy. In our case this evening, we will talk about radiation, but there are other modalities. So the technologies of cryo, HIFU, electroporation, all advanced, but radiation is an old technology that was never used in a way to target it focally, not the whole prostate, and this way to get the benefit of focal therapy with radiation, because we are not going to damage the nerves or other structures. The other important issue is the philosophy of treatment. We always were worried about the fact that prostate cancer is multi-location in the prostate itself, multifocal. And now we adopt the approach of index tumor, and we feel a bit easier to adopt the approach of going after the index tumor, and the other lesions that we are not treating, we have good tools for good follow-up later on. So basically you start with focal therapy, and then for those small satellite location in the prostate, you deal with them the same way like you would do active surveillance, and you'll decide when to fall back on focal therapy instead of going to full therapy that increases the side effects. So let's talk now about the specific of using radiation as a mode of focal therapy. Let's talk now about the form of focal radiation therapy by using brachytherapy, or as we define it, radiation seeds. And I'll bring up a study that was done in Barken Women's Hospital. It was done with MRI guidance. Radiation seeds were implanted in the index tumor. I must add that it was found that the index tumor, their size and their Gleason determined the overall outcome. What was interesting in that study was the fact that they took patients with PSA below 10, Gleason 3+4, and no palpatory finding. That means no nodule was found. And this group of patients were compared to another group, historic group, that were given radical prostatectomy. So it's comparing radical prostatectomy versus focal radiation seeds only in the area where the tumor was seen. Interestingly enough, after 5 years, and you may argue that 5 years is not long enough follow-up, 93% of the radical prostatectomy patient and 93% of the patients that got the radiation seeds, same percentage, were free of biochemical recurrence. And obviously one big advantage to the radiation seeds that were given focally, one big advantage was the fact that there were very minimal side effects, because the radiation did not involve the whole gland and did not involve critical areas that may cause symptoms of irritation, voiding irritation, because of the radiation. So at least on this group of patients, short follow-up 5 years, it showed that the biochemical failure was similar between the group of radiation seeds versus radical prostatectomy. You may argue that the group that had the radiation seeds did as well, probably, as a group that you would have kept them on active surveillance, because the inclusion criteria for the radiation seeds is the same inclusion criteria like patients that undergo active surveillance. The big advantage is that patients prefer to have a minimal intervention compared to active surveillance only. The psychology is they feel better that something was done on the tumor in the prostate. Another example of the focal radiation is in the clinical situation where patients have biochemical failure after radiation. By the nature of the failure of the primary radiation to the prostate gland, it lends itself to having a unifocal area that failed the radiation and can be amenable to radiation again. The study that I want to mention was done at the University of California, San Francisco, 24 patients. What they did, they found by using spectroscopic MRI, multiparametric MRI, they found where is the lesion after failure of primary radiation, and that area was radiated with a high dose of radiation by giving the radiation seeds compacted to that area, and they gave a focal area of 144 gray, and to the rest of the prostate they added 108. So this is a combination of giving radiation seeds focally to the area of residual recurrent disease after primary radiation, and the rest of the gland got total radiation but at a reduced dose in order to decrease the side effect. And indeed the side effects were decreased, and the results were that 80% of the patients were free of biochemical recurrence within 5 years. Let me mention now another study done at Beth Israel Deaconess. They used 10 patients, and they used the DCE, Digital Contrast Enhancement MRI, to try to localize where is the cancer after failure of radiation. And this is a good tool, the DCE, the Digital Contrast Enhancement after failure of radiation, because it delineates beautifully where are the areas that need to have transplantation. And this was biopsied, those areas were biopsied. This area were fused, the area of the MRI, DCE, Digital Contrast Enhancement MRI, was fused with the ultrasound in such a way that the biopsy were guided by the ultrasound with the information from the DCE MRI, and this way they were able to identify where are the lesions that remained after failure of primary radiation. The last mode of delivering focal radiation, I should mention, is done at Beth Israel Deaconess, where they treat the whole prostate in the following way. They define the lesion by doing 3 Tesla MRI, and that will be the index tumor. And for the index tumor, they are using the cyber knife. That means the portion of the gland is treated by cyber knife in a high dose, but only over a period of 4 days or 5 days. And the rest of the gland is given a boost, but at a lower traditional dose that usually radiation is given. This way side effects are avoided. It still remains to find out what are the results, and further follow-up is needed. So as you can see, radiation treatment, which was given for the last 100 years, is now being modified, and it seems like there will be more a tendency to use the focal by itself or focal in conjunction with some boost to the gland, but try to avoid a high dose for areas of the prostate that don't need it in order to avoid the side effect from radiation. Thank you for listening. I hope you'll join us for more video blogs, listening to more video blogs, because we'll keep bringing the issue of focal therapy using different mode of energy delivering. Stay well, stay informed, stay in touch, and have fun. Goodbye.